So good morning, everyone. As usual, this is again a nice Monday when we will discuss a very important topic on telemedicine and telehealth in palliative care. And this topic will be covered by Dr. Bhavna and Dr. Nitin. So, if Dr. Preeti is here, she can introduce both. Otherwise, Dr. Bhavna, please. Dr. Bhavna is faculty at GCRI. And that their residents are taking very good and very elaborative topic most of the time. So Dr. Bhavna, please introduce Nitin and you can start. Thank you.
Good morning all. Nitin is now being second year resident in pain and palliative medicine. He is ever ready to prepare a topic and give a talk. He has prepared this topic also covering everything in telemedicine. Though we are practicing telemedicine in palliative medicine since long, but this is guided, proper guidance and what are rules, everything is prepared in the topic. Nitin, what?
Okay. Good morning, ma'am, and good morning, my colleagues. Today, my topic of presentation is telemedicine and telehealth in palliative care. Myself, Nitin Pandey, I'm a second year resident from GCRI, Gujarat. So, starting with the topics, my objective will be covered in following headings: definition of telemedicine, proposed benefit of telemedicine, technological concept of telemedicine, general application of telemedicine, application palliative care, guideline for telemedicine India, and framework of telemedicine. Can you change my slide, please? Starting with the introduction. As telemedicine covers many activities and technologies, and a single definition is elusive, telemedicine is particularly well suited to rural and remote medicine. New communication technologies are opening up new possibilities in telemedicine and e-health. Data transmission, applicable standards, and bandwidth requirements need to be considered when adopting telemedicine. So, its usefulness, there are several challenges, including reimbursement, licensure for cross-border consulting, and regulatory issues need to be addressed. Moving to definitions, next slide, please. World Health Organization defined telemedicine as the delivery of healthcare services where distance is a crucial factor by all healthcare professionals using information and communication technologies for the exchange of valid information for diagnosis, treatment, and prevention of disease and injuries, research and evaluation, and the continuing education of healthcare workers with the aim of advancing the health of individuals and communities. New England Journal of Medicine defines telehealth as the delivery and facilitation of health and health-related services, including medical care, provider and patient education, health information services, and self-care via telecommunication and digital communication technologies. Another definition of telemedicine refers to the use of communication information technologies for the delivery or enhancement of clinical care. Various aspects of telemedicine includes teleconsulting, telenursing, teleradiology, telepsychiatry, telepathology, and telemonitoring. In general, telemedicine is used to denote clinical services delivered by a registered medical practitioner, while telehealth is a broader term for clinical and non-clinical services such as medical education, administration, and research conducted at a distance. Next slide, please. Next slide. This is previous one. Yeah. Moving to benefits of telemedicine and e-health. Benefits are efficiency and decreased cost, enhancement of quality of care, empowerment of patient and consumers, encouragement of new and enlightened relationship between healthcare professionals and patients, education of patient and health professionals, enabling information exchange and communication in a standardized way between healthcare establishment, extending the scope of care beyond its traditional boundaries, equity by promoting equitable access to healthcare and healthcare information, ethics as an emerging set of issues, evidence-based to underscore the importance of subjecting these assertions to rigorous research. Next slide, please. Appears most beneficial for population in isolated communities and remote regions where access to primary health care can be limited and specialized level care is often impossible to obtain. Low cost applications are possible even in a resource limited settings. Telemedicine may also enhance healthcare access in urban situations, for example, home care support. Next slide, please. Now, technological concept underlying telemedicine. The telemedicine and e-health can be practiced either in a real time, which is known as synchronously or asynchronously. Real-time telemedicine involves two or more parties communicating or exchanging data simultaneously. Synchronous telemedicine provides immediacy and is particularly useful for emergency situation and real-time consultation. Store and forward telemedicine entails acquiring medical data or images, storing them, and then transmitting them securely to another party for later analysis or review. It does not require the presence of both parties at the same time. The initial step in telemedicine requires capturing data such as text, sound, images, and video and converting it into electrical, digital, or optical signals for the storage of transmission. The transmission medium can be wire, fiber, optic cable, radio waves, or microwaves. Next slide, please. When a signal reaches its destination, the device on the receiving end converts or decodes the signal back into an understandable messages such as sound over a telephone or computer, images or video on a television or computer screen, and words or picture on a computer screen. Telecommunication through telephone, now referred to as a plain old telephone system, which is a reliable for audio-only communication. Video teleconferencing is one of the most common forms of synchronous telemedicine, which relies on digital compression of audio and video streams in real time. Video requires a large amount of data to be transmitted. The more data, the better the quality. This can be achieved through compressing the video and audio files digitally. Compression techniques have improved over the last decade, making video teleconferencing more accessible and less costly. The hardware or software that performs compression is called as a codec. The resulting digital data are then transmitted to a digital network of some kind, often via an integrated services digital network or an asymmetrical digital subscriber line. Digital telephone network system designed to allow transmission of voice and data over ordinary telephone copper wires at a better quality and higher speeds. Next slide, please. Now, general application of telemedicine. The first one is the direct patient care. Teleconsultation. Via teleconsultation, a specialist provide either a real-time or asynchronous consultation to health professional remotely with or without the presence of patient. May also involve the transmission and review of medical data, images or videos by radiologists. Real-time consulting is essential in urgent cases such as emergency care. In other cases, telemedicine clinics can be scheduled on a regular basis. For example, telepsychiatry clinics. Telecounseling, direct patient support at a distance using either telephone or video phones. Telemonitoring, sensors capture and transmit biometric data such as blood pressure, heart rate, electrocardiogram, and physical activity. Teletriaging, a typical telephone triage event might involve a call, often after hours, from a concerned family member or patient or for advice. Professional manning, these services often have protocols and increasingly software program to guide them to a series of questions to add in responding appropriately. Teleendoscopy, remote supervision or observation of endoscopic procedure, including gastrointestinal and ear, nose, throat endoscopy. Symptom assessment, handheld personal data assistant or tablet laptop can support real-time assessment of symptoms. Next slide, please. Indirect patient care involves education. Telemedicine, particularly the use of video teleconferencing and audio conferencing, has been supporting distance learning for decades. Health informatics include electronic health records, clinical decision-making supports programs, and health data management. Now, application of telemedicine and telecommunication in palliative care. Home care, home telehealth has been successfully demonstrated in palliative care, but there is limited evidence about clinical effectiveness and cost saving. The patient with a cancer diagnosis are more likely to be suitable for video visits, which suggests that disease trajectory rather than diagnosis of palliative may be more influential in determining the care required and appropriateness of video phone use. An internet-based video phone support program provides care for families in pediatric palliative care services. Text messaging device and video phones were used to connect veterans with a home care hospice program. Patients felt an improved ability to manage their condition at home, and there were fewer hospital admission, emergency department visit, and bed days of care. Next slide, please. After hours advice line, a pilot study suggested that an advice line may improve the provision of palliative care outside of regular office hours. by providing specialist advice. The advice line was used appropriately and was not overwhelmed by calls. Consultation. Video teleconferencing provided direct patient consultation and support for home care staff and primary care physician in rural areas. Symptom assessment, support of care and management. Digital pen technology allows patients to self-evaluate their symptom and transfer the results digitally over a regular mobile phone network from their home to the hospital clinic. The digital data are also useful for clinical research. Education. Video teleconferencing technology has been used to deliver continuing medical education in palliative medicine to community physician, resident doctor, etc. Guideline for telemedicine in India. The professional judgment of a registered medical practitioner should be the guiding principle for all telemedicine consultations. And RMP is well positioned to decide whether a technology-based consultation is sufficient for an in-person interview is needed. Practitioners shall exercise proper discretion and not compromise on the quality of care. 7 elements need to be considered before beginning any telemedicine consultation. These 7 elements are context, identification of RMP and patient, mode of communication, consent, type of consultation, patient evaluation, patient management. Context. Telemedicine should be appropriate and sufficient as per context. The RMP should exercise their professional judgment to decide whether a telemedicine consultation is appropriate in a given situation or not. They should consider the mode, technology available, and their adequacy for diagnosis before proceed. They should be reasonably comfortable that telemedicine is in the patient interest after taking a holistic view of the given situation. According to complexity of patient health condition, the RMP shall uphold the same standard of care as in-person consultation, but within the intrinsic limit of telemedicine. Next slide, please. Now, identification of RMP and the patient. Telemedicine consultation should not be anonymous. Both patient and RMP need to know each other identity. And RMP should verify and confirm patient identity by name, age, address, email ID, phone number, registered ID, or any other identification. For issuing a prescription, the registered medical practitioner need to explicit ask the age of patient and if there is any doctor seek age proof. Where the patient is a minor, after confirming the age, teleconsultant would be allowed only if the minor is consulting, along with an adult whose identity need to be ascertained. An RMP should begin the consultation by informing the patient about his or her name and qualification. Every RMP shall display the registration number accorded to him or her by the state or national medical council on prescription website, electronic communication, and receipt given to his or her parents. Next slide, please. Mode of communication. Multiple technologies can be used to deliver telemedicine consultation. All these technology systems have their respective strength, weakness, and context in which they may be appropriate or inadequate in order to deliver proper care. Primarily, there are 3 modes: video, audio, or text. There may be situations where in order to reach a diagnosis and to understand the context better, a real-time consultation may be preferable over an asynchronous exchange of information. Considering the situation using his or her best judgment, an RMP may decide the best technology to use to diagnose and treat. Next slide, please. Consent. Patient consent is necessary for any telemedicine consultation. The consent can be implied or explicit depending on the following situation. If the patient initiates the telemedicine consultation, then the consent is implied. An explicit patient consent is needed if a health worker, RMP, or a caregiver initiate a telemedicine consultation. An explicit consent can be recorded in any form. Patient can send an email, text, or audio video message, and the registered medical practitioner must record this consent in his patient record file. Now moving to type of consultation. There are 2 types of patient consultation, namely the first consult and the follow-up consult. The first consult means the patient is consulting with RMP for the first time, or the patient is consulted with the RMP earlier, but more than 6 months have lapsed since the previous consultation. The patient is consulted with the RMP earlier, but for a different health condition. Follow-up consult means the patient is consulting with the same RMP within 6 months of his or her previous in-person consultation, and this is for continuation of care of the same health condition. However, it will not be considered a follow-up consultation if there are new symptoms that are not in the spectrum of the same health condition and or RMP does not recall the context of previous treatment and advice. Next slide, please. Patient evaluation. An registered medical practitioner would use his or her professional discretion to gather the type and extent of patient information in the form of history, examination finding, investigation reports, past reports, required to be able to exercise proper clinical judgment. Telemedicine has its own set of limitations for adequate examination. If a physical examination is critical information for consultation, an RMP should not proceed until a physical examination can be arranged through an in-person consult. Wherever necessary, depending on professional judgment of the RMP, he or she shall recommend video consultation, examination by another RMP or health worker, or in-person consultation. The RMP shall maintain all the patient records, including case history, investigation reports, images, etc., as appropriate. Next slide, please. Patient management. Based on the type of consultation, then the RMP may proceed with the professional judgment to provide health education, provide counseling related to a specific clinical condition, prescribe medicine. In health education, and registered medical practitioner may impart health promotion and disease prevention messages. These could be related to diet, physical activity, cessation of smoking, contagious infection, and so on. Likewise, he or she may give advice on immunization, exercise, hygiene practice, mosquito control, etc. Next slide, please. In counseling, this is a specific advice given to patient, and it may, for instance, include food restrictions, do and don'ts for a patient on anti-cancer drugs, proper use of hearing aid, some home physiotherapy, etc., to mitigate the underlying conditions. In prescribing medicine, prescribing medications via telemedicine consultation is at the professional discretion of the RMP. It entails the same professional accountability as in the traditional in-person consult. If a medical condition requires a particular protocol to diagnose and prescribe, as in a case of in-person consult, then the same prevailing principle will be applicable to a telemedicine consult. Prescribing medicine without an appropriate diagnosis or provisional diagnosis will amount to a professional misconduct. Next slide, please. Specific restrictions. There are certain limitations on prescribing medicines on consult via telemedicine, depending upon the type of consultation and mode of consultation. The categories of medicine that can be prescribed are listed below. List 2. It will comprise those medicine which are safe to be prescribed to any mode of teleconsultation. Medicine which are used for common condition and are often available over the counter. For instance, these medicine would include paracetamol, ORS solution, cough lozenges, etc. Medicine that may be deemed necessary during public health emergencies. List A. These medication are those which can be prescribed during the first consult, which is a video consultation, and are being re-prescribed for refill in case of follow-up. This could be an inclusion list containing relatively safe medications with a low potential for abuse. Next slide, please. List B is a list of medication which RMP can prescribe in a patient who is undergoing follow-up consultation, in addition to those which have been prescribed during in-person consult for the same medical condition. Prohibited list. And RMP providing consultation via telemedicine cannot prescribe medicine within this list. These medications have a high potential for abuse and could harm the patient or the society at large if used improperly. Medicines listed in Schedule X of a Drug and Cosmetic Act and rules, or any narcotic and psychotropic substance listed in the Narcotic Drug and Psychotropic Substance Act 1985. These are the medicines which are prohibited. Next step is issue a prescription and treatment and transit. If an RMP has prescribed medicine, RMP shall issue a prescription as per the Indian Medical Council or NMC regulations and shall not contravene the provision of the Drug and Cosmetic Act and rule. RMP shall provide photo scanned digital copy of signed or e-prescription to the patient via email or any messaging platform. In case the RMP is transmitting the prescription directly to a pharmacy, he or she must ensure explicit consent of the patient that entitles him or her to get the medicines dispensed from any pharmacy of his or her choice. Next slide, please. Essential principles. The professional judgment of a RMP should be the guiding principle. An RMP is well positioned to decide whether a technology-based consultation is sufficient or in-person review is needed. Practitioners shall exercise proper discretion and not compromise on the quality of care. Some principles apply irrespective of the mode used for a telemedicine consultation. However, the patient management and treatment can be different depending on the mode of communication used. RMP should exercise his or her professional discretion for the mode of communication depending on the type of medical condition. If a case requires a video consultation for examination, RMP should explicitly ask for it. RMP can choose not to proceed with the consultation at any time, at any time, at any step. The RMP may refer or request for in-person consultation. At any stage, the patient has the right to choose to discontinue the teleconsultation. Next slide, please. Duties and responsibilities of RMP in general. Medical ethics, data privacy, and confidentiality. Principles of medical ethics, including professional norms for protecting patient privacy and confidentiality, as per IMC Act, shall be binding and must be upheld and practiced. RMP should be required to fully abide by the Indian Medical Council Professional Conduct Etiquettes and Ethics Regulation 2002 and with the relevant provision of the IT Act. Data protection and privacy laws or any applicable rules notified from time to time for protecting patient privacy and confidentiality and regarding the handling and transfer of such personal information regarding the patient. Next slide, please. RMP will not be held responsible for breach of confidentiality if there is a reasonable evidence to believe that the patient privacy and confidentiality has been compromised by technological breach or by a person other than RMP. The RMP should ensure that reasonable degree of care undertaken during hiring such services. In case of misconduct, it is specifically noted that in addition to all general requirements under the MCI Act for professional conduct, ethics, etc., while using telemedicine, all actions that willfully compromise patient care or privacy and confidentiality or violate any prevailing law are explicitly not permissible. Some examples of action that are not permissible. RMP should use telemedicine to prescribe medicine from the specific restricted list. RMP insisting on telemedicine when the patient is willing to travel to a facility or request an in-person consultation. RMP misusing patient images and data, especially private and sensitive in nature. RMP are not permitted to solicit patient for telemedicine through any advertisement or inducement. Penalties as per IMC Act, ethics and other prevailing laws. Next slide, please. Maintain digital trail documentation of consultation. It is incumbent on RMP to maintain the following records or documents for the period as prescribed from time to time. Log or record of telemedicine interaction, either by, for example, phone logs, email records, chat, text record, video interaction logs, etc. Patient records, report document, images, diagnostic data, etc. Utilized in the telemedicine consultation should be retained by RMP, especially in case a prescription is shared with the patient. The RMP is required to maintain the prescription record as required for in-person consultation. Next slide, please. Framework of telemedicine. This section lays out the framework for practicing telemedicine in 5 scenarios. The first one is a patient to a registered medical practitioner. Second is a caregiver to registered medical practitioner. Third is a health worker to registered medical practitioner. Fourth is a registered medical practitioner to registered medical practitioner. And fifth is in case of emergency situation. Now starting with the first one, the consultation between patient and the RMP. Specifically, this section details with the key element for the process of teleconsultation to be used in the first consult and follow-up consult when the patient consults with an RMP. Next slide, please. So this is a first consult flow chart in which the patient came here either of video, audio, or text message to an RMP for teleconsultation. The starting with the patient identification and then taking consent. Then on an RMP quickly assess if emergency care is needed or not. If in case emergency case is needed, then yes, he or she will provide the advice regarding the immediate relief measures and guide the patient for appropriate treatment. If it is not an emergency situation, then detailed patient evaluation will be done under the following headings by the RMP. And in case appropriate for management, if the case is appropriate for the management via telemedicine, then management regarding health, the management will be given via health education or counseling or a specific treatment to the for the specific diseases. If and yes, next slide, please. This was the first consult follow chart. Now, this is a follow-up consult flow chart in which the patient came within a 6 month of his first visit or to the registered medical practitioner for his disease or condition, in which the same initial few steps are same as first visit to RMP, in which a patient via the video, audio, or text will be consult with the registered medical practitioner, and by after identifying patient after patient identification and taking proper consult, RMP will quickly assess if emergency care is needed or not. If in case emergency care is needed, then then advice according to the emergency care needed is provided by the RMP. If no, then detailed patient evaluation will be done in a form of history, examination, findings, investigation reports, and past record, and ask for additional information related to disease if RMP willing to do so. RMP may switch the mode of communication if required, like if the conversation is started with the audio form, and if RMP need to know that if he thinks that a video consultation can be done, then he can switch on the mode. Now, now in a follow-up chart is the case, if the case is appropriate for management via telemedicine, then continuation of care will be explained to the patient, like in the form of health education, counseling, and specific treatment. And if the patient have a new complaint in a follow-up, then according to that, the medicine of advice will be given to the patient. Next slide, please. This has been covered. Next slide. Next to it. This has been covered by me. Please, next slide. Yes. Consultation. This is consultation between patient and RMP through a caregiver. For the purpose of these guidelines, caregiver should be a family member or any person authorized by the patient to represent the patient. There could be two possible settings. Patient is present with the caregiver during the consultation, or patient is not present with the caregiver. If patient is not present with the caregiver, the patient is there may be a two scenario. If the patient is minor and the caregiver is not present, then if patient is minor, like age less than 16 years, or the patient is incapacitated, for example, in medical condition like dementia or physical disability, the caregiver is deemed to be authorized to consult on behalf of the patient. Caregiver, next condition may be the caregiver has a formal authorization or a verified document establishing his relationship with the patient or has been verified by the patient in a previous in-person consult. Next slide, please. Consultation between health worker and RMP. The health worker could be a nurse, allied health professional, mid-level health practitioner, ANM, or any other health worker designated by an appropriate authority. This subsection will cover interaction between a health worker seeking consultation for a patient in a public or a private health facility. In a public health facility, the mid-level health practitioner at a sub-center or health and wellness center can initiate and coordinate the telemedicine consultation for the patient, and with an RMP at a higher center at a district or state or national level. Health and wellness centers are an integral part of comprehensive primary health care. This setting will also include health camps, home visit, mobile medical units, or any community-based interaction. Next slide, please. Now, this is a flowchart for teleconsultation between a health worker and RMP. Now, health worker seek consult for the patient. After establishing patient identification, either by video, audio, or text, the RMP and patient identifies themselves and consent is obtained. Now, if RMP will quickly assess if emergency care is needed or not. If emergency care is needed, then he advised first that he advised the immediate relief and guide the patient for referral as appropriate. Now, if this is not an emergency condition, then detailed patient evaluation will be done by RMP by taking history investigation and based on his reports and past record and RMP. If the case is appropriate for management by telemedicine, then management will be given in the form of health education, counseling, and a specific treatment. In a specific treatment, there is a concept of providing medicine. Next slide, please. Yes, and is if management is not possible via telemedicine, then health education and RMP can refer the patient for in-person consultation. Next slide, please. Now, this is a consultation between registered medical practitioner to another registered medical practitioner or a specialist. So RMP might use telemedicine services to consult with another RMP or a specialist for a patient under his or her care. Such consultation can be initiated by RMP on his or her professional judgment. An RMP asking for another RMP advice remains the treating RMP and shall be responsible for treatment and the recommendation given to the patient. Guidelines support and encourage interaction between RMPs or specialists using information technology for diagnosis, management, and prevention of disease. Teleradiology is the ability to send radiographic images like of X-rays, CT, MRI, PET, CT scan from one location to another. Telepathology is the use of technology to transfer images, rich pathology data between distant locations for the purpose of diagnosis, education, and research. Teleophthalmology, access to eye specialists for patients in remote areas, ophthalmic disease, screening, diagnosis, and monitoring. In emergency situation, in all telemedicine consultation, as per judgment of the registered medical practitioner, if it is an emergency situation, the goal of objective should be to provide in-person care at the soonest. However, critical steps could be life-saving and guidance and counseling could be critical. For example, in case involving trauma, right advice and guidance around maintaining the neck position might protect the spine in some cases. The RMP, based on his or her professional discretion, may advise first aid, counseling, and facilitate referral. Now, recent developments. The webcams are real-time video cameras that are connected to the World Wide Web, making video teleconferencing more accessible. With the advent of improved web-based video teleconferencing and wireless capacity that enables connection to the internet using cellular, telephone, or satellite connections, high-quality home-based video conferencing will soon be possible in a more rural and remote areas where other high-speed internet connections may not be available. Currently, such wireless capability is making mobile access to electronic health records and diagnosing, imaging, and information possible, improving support to home care. Common errors. Next slide, please. Using technology that cannot be supported by the local informatics capacity. Using telehealth technology because it is available even though it is not really needed or justified. Failing to ensure confidentiality. Improper patient selection. Improper documentation of clinical decision making done with the telehealth methods. Future consideration of telecommunication and telehealth. The ease of use and cost, legal and policy issues. The practicing across the state, province, and country boundaries has medical, legal, and licensure implication for health professional and patients. Reimbursement, adequate reimbursement, particularly of teleconsulting, remains a barrier. A standard and guideline. The lack of widely accepted standard and guideline is a barrier. Information security and privacy policy. Next slide, please. Now drawing conclusions from today's lecture. Telemedicine has many applications, a number of which have already been used in palliative care. Despite numerous reports of success, several issues need to be considered and addressed. These issues are addressed as a common error and future consideration, including the need for larger studies and more consistent clinical and economic cost-benefit analysis. Successful application requires attention to several factors, including overcoming resistance to change, identifying local champions, assessing the extent to which the innovation is perceived to threaten professional work construct concerning therapeutic relationships, and identifying potential workflow changes resulting from the technology. Uh, these are references for my today's lecture. Declan was Palliative Medicine Textbook and Board of Governance and Supervision of Medical Council of India. Thank you.
Good, Nitin. You have presented well. To
Thank you, ma'am.
telemedicine, this practice is good for patients, patients who are home-based treatment and living far away another state. But it should be with guidelines and every documentation. So that we learned today.
Yes, ma'am.
Any inputs, ma'am? Sushma?
Dr. Bhavna, what is your take home for the opioid prescription through telemedicine?
We should find out the practitioners who prescribe opioids in particular place, particular situation where that state from IAPC list, and we may guide patient to go there and get the prescription if we find it necessary. And usually for opioids, we should not encourage in new or fresh cases. We should in follow-up patients, we may do this, ma'am.
So any from anybody? Anyone wants to comment on this topic? There are very good guidelines given recently by ICMR for telemedicine after COVID. I think I will recommend everyone to read those guidelines. Till the time anybody who is practicing and want to share their experience or any comments.
We do that till 3 p.m. Our nursing staff takes registration number of each patient who call. If not emergency, we take this list at 3 p.m. I mail from my mail hospital mail ID to medical record department and take those files out. Then we see the talk with patient again, and then we guide or we prescribe something.
So yes, very good. I think this is a very good way of I think this will be the best way if we can follow the guidelines and if we can remain safe as far as practitioner is concerned as well as patient is concerned. So we have to know our limitations, that when and how much we can do. So in case if this is can be practiced following guidelines, I think this will be the best way for our country especially. So because telemedicine means like COVID has taught us that this can work really well. And I don't think that any hospital have almost all the hospital, they have practiced telemedicine during COVID, and that is what remained, that patients in palliative care especially, most of the time we tried that they should not suffer. So, and if we really want to give home care, this will work really well with the patient. So if there are no comments, if there are any comments, please let us know, or questions. If there are no comments, I think we can close it. And I will recommend that we should read ICMR guidelines, which has been recently released.
Someone is raising hand, ma'am. Yes, Meenakshi.
Yeah, Meenakshi, please go ahead.
Good morning. Yes, ma'am. Good morning. I agree with Dr. Bhavna. We also follow the same procedure where we record the time at which the patient or the caregiver has reached out to us, and in our OPD we try to close the loop within an hour. But if it's a very busy day, we communicate that after 3 p.m. We will get in touch if it's not an emergency. That's one point I wanted to make. The second thing is we also ask for the UHI, the hospital identification number and the palliative care unique file number so that we can retrieve the file before making any comments or conversation with the patient and their family. And for the purpose of the postgraduates, I just wanted to add that we follow a small uh, system where we record what are the complaints the patient or the family has reached out with. Then we ask questions relevant to the complaints raised. And third, we document what is our assessment of this problem based on the history and the complaints. So we have a working diagnosis, and based on that, we draw up a plan and also a follow-up plan for the same patient. So when we document in this format, it's a brief, but it captures the essence of the teleconsultation. And for the next day, if you need to follow it up, or the next time somebody else from the department is picking up that case sheet, they'll know what has transpired between the palliative care OPD and the patient. So this is the points I wanted to make. Thank you very much.
Thank you,
for
Dr.
the
Meenakshi.
presentation.
Very, very useful comments. I think very, very useful for others, those who are practicing telemedicine and following certain norms. But these are comments are very, very useful. Thank you very much. Anyone else wants to say anything?
I'm Jennifer here, ma'am. Can I
Yes,
add
please
something?
go. Yeah, please, Dr. Jennifer, go ahead, please.
Thank you for the good elaborative lecture and the directions for telemedicine. Like Dr. Sushma mentioned, I think most of us or all of us would have used it during COVID, and we've got good lessons that we have learned, and we continue to integrate now this telemedicine along with now face-to-face. And there are many studies that have come up within palliative care itself on virtual consultations and the advantages of that in palliative care, and also this blended approach which combines face-to-face and teleconsultation. What I also wanted to add was within in our team, it wasn't just a doctor. Once we kind of started the consultation itself with introducing different people whom we thought will require input for that particular patient. So once the doctor finished, I would hand over for the nursing needs and assessment to the nurse. And then if a psychologist was also necessary, so we kind of try to do it like in real life, where the interdisciplinary or other professionals in the team were also able to be involved with the teleconsultation. What I want to ask is, I'm not sure whether there are guidelines for telemedicine for non-medical staff. So if somebody just wanted some nursing care, or somebody just wanted counseling, is there a provision for that or not? I know I have not read this recent ICMR thing, but most of the present guidelines are with for doctors, isn't it? Is there anything that allows other professionals to have independent teleconsultation? Thank you.
Dr. Bhavna or Nitin, do you have any answer for this?
Ma'am, as far as I had read the Indian Government of India Journal or guideline for teleconsultation. In case of this for prescribing medicines, there must be a proper degree for being a registered medical practitioner in and prescribing the medication of modern medicine. There's a requirement of minimum MBBS degree for being an RMP, and above that, if there's a degree of MD, then that's okay. And if a doctor or especially if RMP has a degree of Ayurveda, then he can prescribe the medications only in his only the Ayurvedic medicines over a teleconsultation. Ma'am, yes, ma'am. For other specialties, I had not read any judgment or any line. and that states that other professional can prescribe medicine by consultation with a doctor.
So
I think Dr. Jennifer, we have to go through it, that what exactly should be the protocol for other specialties. But this was I think Dr. Meenakshi has said that we do the same. Psychologists also
Yes.
make huge contribution. Yeah. So
Yes,
when a doctor is asking consult, but Dr. Jennifer is asking that if a patient wants only from physiotherapist or from psychologist or nurse, then what exactly should be the guidelines? So
As a part of palliative care only, this team, anyone can consult. It should be like that, but don't know any proper guideline.
yeah.
so there is a
Yes,
comment from Noreen from Bangladesh. Noreen, can you open your mic and say that whatever you have said?
Hello, ma'am. Good morning. I just want to share our an article we published with this headline, ma'am. When patient doesn't want to discharge because they thought that when they go home they will with a malignant wound or the pain they can't come, or they want to stay prolonged in hospital, ma'am. So when we said that no, you are not alone, we give you a number, emergency number, and anytime this 24 hours emergency service, you can contact us and you can consult with a doctor. We can monitor your medicine. They feel some relief. We found out, ma'am, in this article. So this is the headline that they know that we are with them. And this one I just want to share, ma'am. And this is very helpful. And after COVID, ma'am, what we started set up a WhatsApp and do chatting with the video call, because in the lockdown they cannot come to us. So this is the COVID taught us the video, audio, visual, this imagination. Thank you, ma'am. I just want to share this. Thank you.
Thank you, Noreen. There is one more comment from Coimbatore, Punita Vedi. Do you want to say something, Punita?
Ma'am, regarding Dr. Jennifer's thing, I can add some clarification. I think whenever you provide palliative care as a team, the nurse can sometimes add her contributions, or the therapist or the counselor, but it should always come to a multidisciplinary team meet where one person takes a final decision, and that should be written in the file, documented in the file. The nurse can always go see how the wound is, how is it improving, or she can even talk to the patient on the phone. But finally, it should be discussed as a team and it should be documented. That is what I wanted to add regarding to Jennifer ma'am's comment.
So, Dr. Jennifer, actually, everyone has the same idea that there should be a leader who will guide that these consultations are required and they can take the consultation. But as a independent consult from nurse counselor, I think nobody has clear idea. This is what you wanted to ask now, Dr. Jennifer?
yes, ma'am. Yes, I also agree with the same thing, that because only the doctors, we have a guidance towards this. Like everyone have mentioned, we should make it as holistic as possible, you said, but definitely the lead should be taken by the medical professional to use other team members, but also like mentioned, to document all that has happened. I think that is what most of our people are doing, because this is unique to kind of palliative care. This sort of guideline may not come from ICMR or MCA. So I just wanted to flag it up. Thank you, ma'am.
Yes.
Thank you.
Very good. So in palliative care, as such, we are practicing multidisciplinary. So this should go same in the teleconsultation as well, I think. So
Yes.
thank you very much for thank you everyone.
Ma'am, one more question. Sorry,
Yes,
Sushma,
please.
ma'am.
Go ahead. Go ahead.
Ma'am, one practical question I wanted to ask Dr. Bhavna, yourself, ma'am, and Dr. Jennifer. Like this teleconsultation number, we find when we do share the WhatsApp number to them, sometimes they reach out at really out of office hours for something which are not emergencies, typically it's just based on the convenience of the caregiver. So I wanted to know from the institutions, what is the time range this teleconsultation operates? Is it only working hours, or somebody is always carrying the phone and answering? Because sometimes when you go home, you won't have access to the records. At least in our institution, we don't have access to the records. So what is the practical tips?
I can answer this, Dr. Meenakshi. Actually, proper teleconsultation, there should be fixed hours. These are the hours when they will get all the information. For emergency and out of our practice, there should be a number, separate number. Maybe this number can be same, but it has to be clearly told patient that for the detailed consultation, we will be there for these hours, and you can talk to. I have seen, and this works really well. But for emergency numbers, I think numbers should be there definitely. That only empower the patient, and they feel confident that I have doctor's number. But definitely it has to be told clearly to the patient. Maybe it can be the same number or can be the different number. But again, there will be a tendency from the patient and their caregivers that there will be an overlap. If the same number is same, they may contact you for a small, very, very small reason out of hour. So we can't, in spite of explaining, in spite of making them understand that this is not an emergency, but they will ask. So we have to have a system. I think this is what I can say, that definitely teleconsultation with file, it's like an OPD, and there should be a fixed hours for that. For emergency, definitely we should give number. Otherwise, patient again will not go home, and they will not feel very confident that I am at home and my doctors is available whenever there is an emergency. But we have to tell them that what exactly that emergency, what type of things. Yes, but there will be an overlap. People try to misuse your number, but 90% people, they don't misuse. 10% people still will remain like this, that they will call anytime whenever they have any problem. What do you think, Dr. Jennifer?
Yes, ma'am. So for teleconsultation, it should be primarily mainly for meaning not emergency, because if for emergency levels, we can only do a certain level of assessment and say, you kind of mostly triage the patient and say, we cannot offer anything more than this. This is what I'm suspecting. Now you definitely will need to go into a hospital or will need to go get assessed properly by a medical professional close by. Second thing is, here we were doing mostly things through the institution software and like that. So we were not really using WhatsApp. So I do not have any specific answers to that. It's a little tricky. Again, like ma'am mentioned, most of them may not misuse, but again, I don't know if we have guidelines within India. I think during the COVID time, other countries, actually UK and all, they came up with using social, meaning these WhatsApp kind of things, WhatsApp emails. What are the guidelines to be followed? And that I am not sure India has anything on that yet. We were all talking about that during COVID times, but whether we have guidelines on what sort of medical communication and thing can happen over WhatsApp, whether we have guidelines for that, I think the answer is no. And we have to be a little careful when it comes to emergencies. I think the maximum we should try and do is triaging and directing, because some of it really the full assessment can be done only real time, face to face. This is
So
my,
thank you, Dr. Jennifer. I think there are many things we have already learned from COVID and telemedicine, but there are so many things which we have to learn. Today only, there are so many unanswered questions we have left. So there are so many things we can do in telemedicine area, and we should try to do as best as possible. Till the time physician is safe and patient is safe, it is our responsibility that we can continue telemedicine. But if you think, as Dr. Jennifer said, that patient needs face-to-face consult, I think we should call patient in emergency or in OPD. And if you think that I am not feeling very safe in writing or prescribing medication right now, please don't do that. So many things we have to learn. Still, there are so many gray zones and gray areas, and we will keep learning and keep doing. We will continue, because this is the best way I can say that when patient is far away, and technology has given so much of advantage that we can talk to the patient. We will continue with the patient, treat this methodology, but definitely we have to be very safe, and our patient should be safe. Thank you, Dr. Bhavna and Nitin, for a very important topic. And Nitin has given a lot of detailed aspect about this topic. Thank you very much. And thank you everyone for joining. Next week, we will see you on Monday before 6:30. Thank you.